So the aim of radiation is we give maximum dose to the tumor and minimal dose to the surrounding tissue. We have a lot of latest software available. We have advanced radiation oncology units where we should be like kind of Bahubali. If you have seen the picture of Bahubali, where he kills
Yes,
the
yes.
kills the enemy and he will save the his team, actually his people. So the
Right,
radiation
right.
oncology should be in that way. So kill the tumor and we need to save the normal tissue. So that's the
Yeah,
role of
yeah, yeah.
radiation oncology. So radiation oncology are kind of Bahubalis.
Hello and welcome to the Care Compass. I am your host Subodh Simha. In this show, we explore the world of healthcare where science, skill, and compassion come together to improve lives. Today, we dive into radiation oncology, what it is, how it works, and why it's a vital part of cancer care. We'll explore these topics and more with Dr. Raghavendra D. Sagar, consultant radiation oncologist at KLE Cancer Hospital, Belgavi. So, stay with us. Dr. Raghavendra, welcome to the Care Compass. To begin, could you briefly share your journey in radiation oncology and also tell us what drew you to choose this field as your specialization?
So I started my journey way back in 2008 when I took this radiation oncology seat at MS from my medical college, Bangalore. So initially I was not knowing what actually is radiation oncology. That's actually a new branch for many of us actually at that generation. Now, because of the latest technology, many of people are knowing this radiation oncology field. Back then, we didn't had that opportunity because hardly we had any curriculum in the UG level to as a radiation oncology branch as such. And so once I took this branch in 2008, so I completed my postgraduate in 2011. So 3 years on a stretch, and then I started learning this branch because a lot of cancer patients actually we were seeing, and we and lot to learn from them. Not only the treating of a patient as such, but to how to deal with actually social, emotional, spiritual issues, and even the psychological issues of the patient as such. So once I had done that MD radiation oncology, I started as a chief consultant radiation oncologist at Belgaum Cancer Hospital, Belgaum. Then I moved to that is for 3 years actually done from 2011 to 2015. So then I moved to KLE Cancer Hospital, Bagalkot, where I
Okay.
had done as a consultant radiation oncologist and chief. I was chief there. So almost 3 years I done there. Then I have moved to Maharashtra for almost one year as an in charge head of the unit. Then I moved to Raichur also in North Karnataka, which is situated in North Karnataka. So we had a
Yeah.
plan to start a cancer unit there because it's a very backward area as such. So a lot of
True.
cancer patients were there. So we tried doing there also, but somehow because of the investment backup, we didn't do that. Then I rejoined this Belgaum Cancer Hospital. It was overtaken by KLE then. So
Yeah.
almost it's been 2020 now. I
Yeah.
started my journey again back in Belgaum. So as a consultant radiation oncologist, I'm doing as well as assistant professor in the Department of Radiation Oncology, Jain Medical College, Belgavi. So I
Right.
love started this batch and almost I treated around 7,000 cases, cancer cases so far. So
Wow.
that was been a tremendous journey to begin
Yeah.
the radiation
Very
oncology.
true. Quite interesting, doctor. You are both a professor at JNMC. I heard you right, the
Yeah,
JNMC College,
Jain, Jain.
and you are also a consultant in radiation oncology at the KLE Hospital, KLE Cancer Hospital, right? Now, how do you manage both professor teaching as well as the practicing as a oncologist? In fact,
Yeah,
just to add here, it reminds me of a fictional Dr. Jones from the Indiana Jones movie.
yeah.
He is a professor by day and an adventurer by night. Was he your inspiration?
So definitely, because thing is, what we have the professor. Actually, thing is, as a assistant professor or whatever the professor may be, so we enjoy that post because as a medical college, there are a lot of things because academic activity has to be there for
Yeah,
each and everyone to keep
right,
ourselves updated. So
right.
we deal with a lot of teaching and faculties, teaching as a teaching for students,
Mm,
teaching for other departments. That
yeah,
is actually a job. And apart from that, we treat the cases as a consultant. So that's a different altogether. So the
right.
club of teaching as well as treating the cases is actually important for oncologists to keep because nowadays we see a lot of cancer trends changing and the protocols are being updated even
Yeah.
more and often. So that's the reason we want to update ourselves day by day. Uh, this is kind of sandwich and we enjoy the posts.
Okay. So two roles, one purpose, contributing to the cancer care in every way you can, right? So
Yeah.
teaching as well as practicing, right? Oh,
Yes.
wonderful. Very inspiring, doctor. Very inspiring. Now, is it common in medical field for the doctors to do both teaching and work as a surgeon or a clinician, a clinician at the same time?
Yeah, this is very much possible. So it's like how you manage that time that is
Yeah.
important. So because many of
Okay.
the times what will happen is surgeons have a different perspective in the because they'll be having majority of the times in the OT. So once they finish the OT, they will come back to the teaching part. But you need to
Right.
segregate the cases because there are so many cases cancer trend going up day by day, and we need to segregate and we had a protocol, proper protocol in the department how to go about
Mm.
because we have almost 3 to 4 radiation oncologists in a department and
Okay.
day we get the cases and we have a division of OPDs and we divide the case accordingly and segregate what thing to be done and what time to be treated and other things. So it's a management of time purely. So with respect to profession as well as with as a consultant what you work.
Okay. So learn, practice, and teach.
Yeah.
Right? It's complement each other. Exactly. Okay.
Yes.
Wonderful. Well said, doctor. Before we dive into your specialization, that is radiation oncology, let's talk about cancer, doctor. Once rare, this disease, it is on a raise now. And what is driving this raise, and how can people prevent cancer in their daily life?
The cancer was there before also. Thing is the awareness and even the screening has actually improved over a period of time. So if you think on the way back in 50 years back, there were a good number of cancer patients actually, but people had a different perspective on the way they think of cancer because they thought in another way around. But now the things have improved and it is like we have so many screening tests available. We have a lot of awareness programs going on now each and I think even at the village level also we do the cancer awareness screening. So people nowadays are coming to know actually what actually is a cancer, how actually it presents with, so what are the signs and symptoms of cancers. So this is like awareness and screening has actually made a way for detection of more and more number of cancers, especially in the early stage.
So you said early detection, right? So what does the early detection mean, and how does it change the outcomes for the patients, doctor?
Generally, in the sense like if we are detecting the cancer cases in early, the prognosis and survival of the patient is far better. So
Hmm.
in cancer, we have a staging stage 1, 2, 3, 4 generally.
Yep.
Stage 1, 2, 3 usually the disease are usually controlled. We say that 5 years survival. If we say example, if we say like cancer of head and neck, the five years survival. Let's say in stage 1, we see around 90%, 90 to 95%. In stage 2, we see around 75 to 80%. In stage 3, we say 40 to 40, 50%. And stage 3, 5 years survival is around 20 to 30% or sometimes 10 or 10 also. That depends upon so much of prognostic factors and even the patient, whether general condition of the patient, the performance status of the patient, and so that everything comes into one group. So we have a protocol for that, how to categorize the patients based upon the staging and other things. So staging do matter a lot. If you think of breast cancer coming in the early stage, for example, I'm telling you, uh,
Mm.
breast cancer in the early stage, if they come just as a local excision, what we call lumpectomy, followed by radiation, what we give, followed by chemotherapy. So the cosmetic issue or the functional issue will be taken care, and the patient are psychologically also far better compared to the whole removing of the whole breast because those present in the advanced stage. So we
Yep.
need to remove the whole breast away the psychological patient and in the is one of the important thing that has to be considered. So early and late. So if you consider this is a major thing what we come across. The prognosis as well as survival of the patient do matters a lot in this based on the
Okay.
stage.
Great clarity, doctor. Yeah. So let's dive into your specialty, that's radiation oncology. To begin with, could you explain what exactly radiation oncology is all about and how it differs from the medical oncology and surgical oncology?
So radiation oncology generally is a branch of science only that deals with the use of ionizing radiation in the sense that's the use of purely X-ray or gamma ray or a charged particles.
Right.
So unlike in the this thing, the layman term, what they say it's kind of current they say or they say radiation will burn the whole body as such. It's not like that. It's a use of ionizing radiation which will not. It's a non-invasive one. It will not
Yeah.
cause any pain while giving radiation. So it's a
Hmm.
branch of medicine that usually deal with the use of ionizing radiation for the treatment of cancer as well as a benign disease.
Right.
This is the one. So medical oncology, if you see, like it's a giving of injectables, what we say, either targeted agents or a chemotherapy agents or
Yeah.
immunotherapy. So they give injectable. So
Yeah.
chemo is a form of chemotherapy is a form of systemic treatment. Whereas radiation as such is a local regional treatment. We address the local region where the surgery has been done or
Yeah.
upfront before the surgery, and also the regional nodes. Sometimes what will happen from the from primary tumor, the node there is a spread to the lymph nodes area, what we say. So
Yeah.
that will be addressed by radiation, local regional form of treatment. Even the surgery
Oh,
is also a form of local regional treatment. So it's kind
right.
of invasive when compared to the surgery and other things, and we use ionizing radiation. So in this thing, if you compare with the radiology, where they use kilowatt kind of X-ray, but we use mega voltage range. So mega
Mm-hmm.
in the sense which causes destruction of the cells. So the aim of radiation is we give maximum dose to the tumor and minimal dose to the surrounding tissue. We have a lot of latest software available. We have advanced radiation oncology units where we should be like kind of Bahubali. If you have seen the picture of Bahubali, where he kills
Yes.
the
Yes.
kills the enemy and he will save the his team, actually his people. So the
Right.
radiation
Right.
oncology should be in that way. So we need to
So
kill
it's a
the tumor.
precision, right? What
So we need to
targeted a precision kind of a thing, right?
so we
So
need to
yeah.
kill the tumor and we need to save the normal tissue. So that's the
Yeah.
role of
Yeah. Yeah.
radiation oncology. So radiation oncology are kind of bahubalis.
Yeah, yeah, got it. So very good analogy. Now, how exactly it works, doctor? How does that Bahubali thing or the precision which you're talking about, right? Like not affecting the surrounding area, but it goes exactly precisely and go and hits that one. How exactly the mechanism works?
Yeah, this is we have a latest technology called IMRT, that is intensity magnifying radiotherapy. Intensity
Okay.
modulated radiotherapy can also be said, and we have something called VMAT, volumetric modulated arc therapy, and we
Yeah.
have IGRT, image
Okay.
guided radiotherapy. So, and even we have a stereotactic body radiotherapy, stereotactic radiosurgery, stereotactic radiotherapy. So these are the different techniques which are available, and each technique has got their own advantages and own disadvantage. Advantage are many, disadvantages are very few. And usually the selections will be done based upon the patient criteria and the site what we are treating. So this IMRT and above technique, what I am telling you. So it has got a software in such a way that we usually contour the tumor and where it has spread. And we contour in the sense we delineate the tumor as well as where it has spread. Like as a radiation oncologist, 3 years we have learned so many things in the during PG life. So we contour all the tissues, normal tissues, and as well as tumor tissue and surrounding tissue. So once we give this dose constant, what we say. So each organ has got some dose limit. Say like tumor, it has got a dose limit of if it is surgery is not done, it take around 66 to 70 gray, or if the surgery is done around 60 gray. We usually give the dose. And a normal tissue has got the dose limit. So each one has got the dose limit. So if you cross that dose limit, then the patient will be having the toxicity. So that we have that software where we modulate the beam in such a way that the tumor receives the maximum dose, whatever we intend to attribute, and a very minimal dose or within limit dose to the normal tissues. So in this way, we avoid the toxicity and we deliver the dose to the tumor and thereby able to kill the microscopic or the macroscopic disease which is
Right.
present. So this is
Okay.
the beauty of IMRT and above technique what I was mentioning before.
Right. Right. Now, there are a couple of things you talked about, right? You said IMRT, IGRT, and stereotactic is what you said about, right? How do you decide which radiation technique to go for a given patient's case?
So generally, if we see IMRT is usually recommended for majority of the patient. So IMRT for even head and neck cancer, so
Hmm.
breast cancer, so
Yeah.
for esophageal cancer. So IMRT usually recommended. So IGRT is other one of the option where we take this motion into consideration. Motion in the sense is a 4D, four dimension. So
Okay.
X, Y, Z coordinate as well as the motion into picture.
Right.
So
Yeah.
the moving tumors will be targeted with the help of IGRT. So
So I'll
especially
just interrupt you. Motion means is it the movement of the organ or something like that?
movement, yes, movement
Tumor.
of the
Tumor.
yes,
Okay.
yes, movement of the organ.
Okay. Okay. Got
Yes,
you. Got you.
like say kidney, lung
Mm-hmm.
tumors, okay,
Mm.
pancreatic tumors. So
Mm.
these are the moving tumors. So when I take
Right.
the inspiration or expiration, the if I have a tumor in the lung, it will start moving. Inspiration, expiration. So
Mm-hmm.
IGRT has got the specialization for treating those tumor IGRT. So IMRT can
Yeah.
be done for a majority of the patients. and IGRT for generally for moving tumors because it take into 4 dimension into consideration. And stereotactic radiosurgery is
Mm.
for the actually brain tumor, stereotactic
Okay.
radiosurgery, where we
Okay.
deliver very high dose, say around
Yeah.
25 gray. Like generally that dose protocols are different for different tumors as such. So
Mm.
stereotactic radiosurgery is delivery of only single fraction of radiation, high beam radiation, or high dose radiation to the brain. Stereotactic
Right.
radiosurgery. So this will be done by radiation oncologist with incorporation of neurosurgery as per radiologist. And in
Yeah.
stereotactic radiotherapy, we deliver dose of say around 3 to 5 fractions of radiation is what we generally give. This is
Okay.
also for the brain tumors and even for the other like skull-based tumor, what we say we can give. So once we come below that skull-based or whatever, the other thing is stereotactic body radiotherapy, what we say. So we can also
Mm-hmm.
deliver the dose, say in the form of 5 fractions for all the either like moving tumors, we have IGRT into incorporation for that, or for other tissues also like recurrent tissue. If the
Mm-hmm.
patient has already underwent cancer-directed therapy, where they come with the recurrence, so these options of stereotactic body radiotherapy, so not radiosurgery, but body
Yeah.
radiotherapy below
Right.
that, whatever
Yeah.
the base of skull. So we do that body radiotherapy. So usually high dose 3 to 5 fractions will be given. So, but with respect to IMRT or IGRT, where we deliver the dose in a fraction wise, say around 15 fractions or 25 fractions, that again depend upon the tumor site of the tumor and what actually we are treating it. That depends upon. So there are
So,
varieties of techniques available. The choosing will be done based on the site of the tumor. Even the financial consent will be taken into consideration because majority of the patients what we get in our this thing are below BPL holders, Ayushman card holders, where the
right.
government don't give the facilities for that the latest technology. So they just
Mm-hmm.
give the basic option of what we 3D CRT what we say. And nowadays the 3D CRT hardly we use because IMRT once we know as a radiation oncologist we want to give the better outcome for the patient and better quality of life. So we
Yeah.
do IMRT for all the patients, and we generally avoid this 3D CRT and below techniques, which are usually kind of outdated techniques, what we say. So
Right.
these are the different techniques available in our practice. And we are giving at a KLE Cancer Hospital, we have all the technologies available.
Yeah.
So that is one of the best thing.
I was about to ask you this, right? Whether KLE has all these capabilities and all, you answered it. Okay.
Yes,
That's
yes,
great.
we have
So,
all the
yeah.
technique available,
Yeah.
and we usually
Okay.
counsel the patients before giving the treatment. We take almost half an hour to 1 hour. We discuss
Yeah.
with the patient and the patient attendant. So what actually you want? So with respect to the outcome of the disease, with respect to the prognosis, with respect to
Yeah.
the quality of life. Though we say that cost is one of the constant in majority of the patients, but we do counsel the patient and motivate them at least. They have a good quality of life because once the radiation what we deliver can't be taken out. The once
Correct.
delivered is radiation is delivered. Either you give
Yeah.
it a 3D CRT, IMRT, IGRT or whatever. Once
Yeah.
radiation is delivered, it can't be taken back. So the
Oh,
normal tissue organs have reached the limit and we should not cross that limit also.
right. So, yeah. So all these have got to do with the external beam, right? Which has been
Yeah, yes, yes,
targeted
yes.
to the,
So
correct?
everything what I told is external beam radiation
Yeah.
therapy.
Yeah.
So we have something called as internal radiation, which is called
Right.
brachytherapy. So brachytherapy is kind of different altogether because this is kind of OT procedure, minor OT procedure, what we say,
Yeah.
or sometimes we do under sedation also. So most
Right.
commonly the in brachytherapy we treat cervical cancer,
Yeah.
endometrial cancer, and cancer of
Mm.
vagina. So even the interstitial, this is like intracavitary brachytherapy and interstitial brachytherapy. Interstitial also
Yeah.
we do for cervical cancer in majority of cases, and prostate cancer, breast cancer can also be treated with the help of this internal
Mm.
brachytherapy, where we put the applicators inside the patient body. The radiation source, what we have, the radiation source is in the form of rice grain. So around 5 rice grain radiation source will
Yeah.
be there, and this will go inside the applicator to the designated time, whatever the
Yeah.
dose what we wanted. So it will deliver the dose what we decided, and it will again retract and go back to the machine, which is a brachytherapy machine. It's a very small machine, compact machine.
Yeah.
So
Okay.
which is so it will deliver, and again the source will go back to the machine and will be stationed there. So also, so we have a medical social workers also, and we have physiotherapist also. So each and every tumor will be discussed in the tumor board. So where all the specialty will be sitting, either radiation, medical, surgical, pathologist, physiotherapist, and medical social workers, physiotherapist, psychologists, all will be sitting at. We will be deciding the patient protocol and will be telling this is the what is the protocol what we have designed, and will be delivering this is the how we deliver for you, and we take the patient into confidence, and once they are confident enough, then only we start the procedure. And in each step wherever the patient goes, there also we or our subordinate will go and check whether it is correct or not, even whether the patient has any issue with that, we address that issue also.
Incredible, doctor. In fact, I was about to come and ask you about that, since there is a multiple specialty and beyond that. I can just say that, radiation oncology is the one. Then there is something called surgical oncology, which you explained just now, medical oncology. Now, and there are many more in the typical cancer care setup, right? Now, how do all the specialties, they work together for a given patient?
Once we have this tumor board, actually, I think this will happen a kind of if patient we see a lot of cervical cancer patient, breast cancer, and head and neck.
Yeah.
This already we have formed the protocols how to go about, and some of the exceptional cases will be there. So for that, usually we sit weekly once. We decide the protocol. Our one of the resident or the duty doctors, they will present the case scenario. Once they present, we actually properly stage the disease, and then we decide whether to go with the radiation first, which is a neoadjuvant radiation, or after surgery, which is called adjuvant radiation, or as a definitive, in the sense only radiation as well as chemotherapy will be given,
medical
or as a palliative. So the radiation roles will be defined there, and even the surgeons also will be like sitting whether they want to go with the chemo first, radiation surgery first, or other thing first. So as a radiation, we plan either definitive or neoadjuvant or adjuvant or in a palliative setting. So these are the four settings usually that we have into our radiation oncology field, and that will be decided after proper staging of the disease. Then the protocols will be designed. It's an individualized, personalized care for the patient.
Wonderful. It's like a 3-layer safety net, right? Each specialty complementing the others.
Yes.
And typically a multidisciplinary care, what I can summarize in this, right?
Yes, definitely, because it's a multidisciplinary team approach only because each and every patient, they require surgery at point of time, or radiation. Almost 70 to 80% of the patient, cancer patient, require radiation at any point of time, and even the chemotherapy also at one point of time. If there's a recurrent disease or a metastatic disease stage 4, the chemo actually will come into picture. So all specialties has to be
complementing each other.
These are the main 3 pillars of cancer.
Cancer care, exactly. Right. Doctor, interestingly, I wanted to know about it, right? So, have you treated a patient where surgery was too risky, where the radiation was the only option left, and then it worked well?
Yes, we have treated on a case of a brain tumor actually. So, the patient had this comorbidity where they had a cardiac issue. And even if this kind of high risk, even if they have any cardiac issue, usually patient will not be operated. So that brain lesions, 2 brain lesions were there. Actually, I treated the brain lesion only with the radiation. And after doing a follow-up after 3 months or 4 months, actually both the brain lesions disappeared with the radiations. That was the beauty of the stereotactic radio surgery what we had that time. So we have given that stereotactic therapy, and the results were amazing. And other case of lung tumor where it was inoperable because of the medical contraindication. So it actually was a small tumor where we have delivered with the stereotactic body radiotherapy with the 5 fractions radiation dose, and it's got excellent results. So because we assess the patient before we do the scan, and after assessment, usually after 3 months, we repeat the scan, either PET CT or other thing we usually do, and assess how much the response is there. So we got a very good results. When surgery was not done, only the radiation was done in that case.
And this was done at KLE, Cancer Hospital.
Yeah, it's available in our KLE. And
KLE,
advantage.
Wonderful.
So this is one of the unit in North Karnataka as such, where all the facilities are there, and even as a consultant, will be happy to treat. Even the patients themselves find happy once they treat, and when they are declared as a disease-free kind of that your tumor burden has reduced, and now there is no disease, they also feel very happy. It's kind of mouth of words, and even they tell other patients and other this thing also that
The
they
referrals.
use
Yeah.
yes
Hmm.
kind of referrals for this thing.
Referrals.
So
Yeah.
we don't
Hmm.
do kind of, but we do a lot of actually marketing activity, but it's kind of patient satisfactory that determines, and they pull other patients that I have been cured for the disease, and it's like you can come over and take the treatment. So in this way, the KLE actually has picked up in a lot of cases. Initially, we last year we did around 600 to 700 cases. Now this year actually we have reached almost 1,100 cases in the
Oh,
radiation oncology. So almost 400
fantastic.
cases more we have treated. So this is a
Yeah.
huge burden on the disease. So it's I assure
Very true.
I should thank the marketing people and even our managing director, even our CEO also for that, because their efforts have been made literally a good thing in our cancer field.
Fantastic, doctor. Nice. Good to hear about it. And then word of mouth is the one which is very, very powerful. Somebody who has gone through it and experienced that, and he felt satisfied with the successful of surgery and all, and definitely will go and tell this to the others. And that's how the credibility of the hospital also will grow with the doctors as well, right? So, yeah. Doctor, one quick thing to know about it, right? Patients often hear diagnosis and prognosis, right? The diagnosis identify the disease, and prognosis is actually is a statistical probability of what may happen, like
Mm.
survival or recurrence and all. Now, the core thing to be for all our viewers, right, who would like to really hear out from you, how much importance should they give to survival statistics for their own case?
Thing is, each and every patients are actually unique. So with respect to the
Yeah.
staging or with respect to the general condition of the patient, with respect to the histology, what we get, the biopsy report, that we get the histology. So each and every patients are unique. So usually many of the patients do ask, so once after the diagnosis, either with the help of biopsy or CT scan or MRI, they have detected tumor, and now it is proven with the help of biopsy that they have confirmed the cancer case. So once the diagnosis is done, majority do ask, even the educated also they ask, what's the prognosis, how many years or months are left to me and other things. So it's like case by case. Actually, this is very difficult to tell to the patient also, because we are not God. So
Hmm.
I tell to the patient that so if they come in a stage 1, 2, or 3, usually you will do well. But in stage 4, actually we don't give that much this thing also, but we tell them so the prognosis is not that bad also, but we try for a hope, and we should be thinking positively. So because positive nature of the thing, once we inculcate in the patient, they actually tend to cooperate well with the treatment and they complete the treatment well. Or else usually what will happen is, once if I tell it's a stage 4 disease and you are hardly left with any treatment, even they reluctant to take the treatment also, they will not take treatment and they will
Hmm.
just sit in their home and do that. So
Yeah.
our aim is to psychologically counsel them and make sure they get the good treatment, because once they get the good treatment, even the quality of life also will be good, and even
Yeah.
the number of days left or the number of months left is not in our hands actually. So but
Hmm.
case by case, we have a lot of difference, different based on the whatever the criteria I told before. So generally, we don't give that assurance of 100% hope that you will be
Right.
there for the other 5 years. So generally, we say 90 to 95% the disease will be controlled. 5% chances we never know what will happen. It's not in our hands also. So we'll give the best and the best form of treatment. Let's think positive and go ahead with the treatment. What actually I say for the patient.
And the statistics is basically is just a perspective, right? Because they
Yes,
should,
it's
yeah,
kind of
correct.
question that
It's
actually is
perspective.
high volume centers, if they have, they
Yeah.
actually had formed the protocol like this is the stage wise, it has been fit as a stage 1 based on the general condition, based on the performance status of the patient, based on histology. And so there are a lot of other things to be considered. Even the comorbidities like I mean, diabetic, hypertension, or ischemic heart disease, or any brain ischemic hemorrhage is what we say. There are so many things to be taken into consideration. So this is like individualized, and we can't tell the patients that this is a one and you will be there till so months and so years will be there. For the patient.
Wonderful, doctor. Well explained. Many patients look for a second opinion. How does your team help them to get a thorough, efficient second opinion? Somebody is trying to already has gone to some other hospital and would not like to take a second opinion from the KLE hospital. Let's say about radiation oncology only, typically, right? How does
Actually,
your team?
so second opinion usually is again
Yeah.
the patient choice because we should respect the patient their
Right.
autonomy. So
Yeah.
so they have the justice, they have a right to demand that I will take the second one. So you can't just pull the patient. No, this is the final. You can't take the second one. So it's a patient. We need to respect the patient and decision. So let them take second opinion or third opinion, whatever possible from the different hospitals or from the different consultants anywhere in Belgaum or outside the Belgaum or in India. So majority of the times, so what we practice is ethical based practice. So we have something called evidence based practice or ethical ethics. So that keeping in mind all the protocols what we have in day-to-day practice, it's evidence based medicine what we say. So the
Hmm.
with respect to the evidence based medicine only we practice all this protocol and
Yeah.
no deviation. Even if they go to the other centers, I think some of the other consultants they tell the same opinion and give the same assurance as such. So the hardly any 5% difference will be there in terms of counseling part or in terms of patient how they take that into consideration. But generally, majority of the patients once we tell as in a KLE cancer hospital once they come, they have satisfied enough and they usually give that that we are satisfied and whatever you told is the right one. So until unless what I say is they should be expert opinion. If I'm a radiation oncologist field, they should take the opinion from radiation oncologist, not
Yeah.
from the surgeons or not from the any other
Right.
practitioner, not practice outside. So that will have a false impact because if it's a dermatologist or orthopedician telling about the cancer is not a big thing, so you should not tell. So it's always expert based. They should consult the expert only. Then they'll be satisfied what I feel. So we don't
Okay.
have any
Beautiful
objection.
explanation.
Let them take the second opinion. It doesn't matter for that.
Yeah. Wonderful. Beyond the clinical results,
Beyond
what
them.
makes the patient experience at KLE Belgavi stand out compared to Western countries? Especially when we talk about the cost, comfort, and a truly personalized services, personalized care.
So this once this KLE Belgaum Cancer Hospital, KLE Sampath Kumar Sheni Cancer Hospital came into picture. So our chairman, Dr. Prabhakar sir, has had a bigger vision because
Hmm.
he put all the latest equipments under one roof. We had the radiation therapy machines or as a
Hmm.
surgery where they got the robotic surgery into
Yeah.
picture or the advanced latest chemotherapy, whatever they have. So we have actually tried to fix the package as low as possible, considering the surrounding places and even the other thing. If you go to the metros, the rate are almost 3 times to 4 times more. But we have
Right.
kept a
True.
very nominal rate so that because this part of the patients, they affordability is a big questions. So though we have kept the least rate for the packages, and so that it will be easy for the people also to take with the help of whatever if they don't have any insurance, private insurance, or if they don't have any BPL card or the Ayushman card or some other insurance so they can afford at least to minimum package what we have. And as far as KLE Sampath Kumar Shivani Cancer Hospital is concerned, so all under one roof. So you name the service, we have the service. That's one of the advantage what we have in our
Hmm.
hospital.
Okay. And before we wrap up, doctor, for someone who has just been diagnosed with the cancer and is looking for a treatment options across the world, what is the single most important piece of advice you would like to give them?
So once the patient have been diagnosed with the cancer or in looking for the treatment, I usually advise them always take the expert opinion and don't Google it and say don't Google and you judge the treatment based on this whatever the because if you type the positive thing in Google you'll get the positive results. If you type negative one you'll get the negative. So always seek the expert advice and so myths, there are so many myths related to radiation, there are so many myths related to cancer survival that has to be properly counseled. So the counseling part and the seek proper expert advice and avoid this Google this thing so that they can come at that particular place, take good form of treatment and will have a good quality of life and also good survival and prognosis in the future. What I say.
Okay. So don't Google, don't chat GPT. Always reach out to the medical experts, right? With any problem that you have for the
So we
diagnosis.
are there
Fantastic.
to help, and we have a good marketing team where they share the contact number of the
Yeah.
doctor first, so where they can reach out.
Reach out to the experts.
Calling just they can call the hospital and consult the doctors. Even we are available 24/7 over the phone, so they can always text us, even WhatsApp us also. So that is one of the advantage what we have in KLE in Sambat Commercial Cancer Hospital.
Thanks, Dr. Raghavendra, joining me on the Care Compass and sharing your insights. And you made a complex topic very easy and interesting for our viewers. And it was a great having you on this show, Doctor. Thank you so much.
So thank you very much. I enjoyed that show.
Hope you found this conversation meaningful. Don't forget to like, share, and subscribe. Your support helps us to reach more people seeking trustworthy health guidance. Until next time, stay informed, stay healthy, and take care.